Okay, all the buttons are pushed. So mechanisms for engaging business and health improvement. My talk is going to, again, rely upon a couple of assumptions, and just like Kathy's did, so you've seen this already. But I show it again to remind you of the fact that there are different determinants of health, that healthcare is, clinical care in this diagram is only 20% of healthcare, and that in the paper that David Kindig and I wrote, we remind people that in order to make progress on health across all these determinants, it really requires a collaboration and action on multiple determinants by multiple actors. So I do that. The second thing I ought to say is that much of what I'm going to say, although it's me here at the microphone, is dependent upon the collaboration that David Kindig and I have had in thinking about this. If I say anything, characterize it poorly or misspeak in any kind of way, it's my fault. I'll rely upon the partnership for all of this. So what will cause business to engage? And this was the first panel, but I couldn't resist, at least at a high level, sort of, and I did this before I heard the panel this morning, and just reviewing this. One, altruism obviously is a tremendous motivator for action. And I think it exists in the business community, it exists in healthcare, it exists in a number of fields, but of course it isn't uniform across all participants in business, all participants in healthcare, or human beings. So it's not necessarily sufficient, but it is important. Market image in the mind of the customer, and I'm going to talk a little bit more about that. Improved value of products and services, that point's already been made. Improved health of the workforce through less costly inputs, increased productivity, workforce motivation, improved community environment for business, for more and better customers. I think that point was made by Kathy earlier. Improved national business competitiveness, improved national defense, and that has already been mentioned as well. I had the opportunity to facilitate a conversation between the U.S. Navy and healthcare organizations in San Diego a couple of weeks ago. And the Navy is very clear about the fact that increased healthcare costs eats into the ability to deploy the fleet to the Pacific for the purpose of national defense. And so it is a range of reasons, from altruism right on down to national defense. And then the last bullet, it's our view that aligned self-interest and community interest needs to be really at the core of engagement. That all kinds of things happen, or all kinds of reasons there are for people to engage and do things, but you really have to appeal to what is important to the stakeholder if you're going to get them aligned to participate in common purpose. So I apologize for this diagram, but I've been thinking about the Harvard Business School and the Harvard Business Review. So this diagram is from Strategy Maps by Kaplan and Norton, where they talk about, in their book, how to create a value. I use this particular example because HealthPartners is a large business corporation, $6 billion in revenue. We use a variant of this approach in order of trying to describe how we create value for our customers in terms of our strategic planning. And so, busy chart, financial I'm going to start at the bottom, the learning and growth perspective, our internal assets that the company has or the firm has. Second is internal perspective or processes that create value. That builds back to a customer value proposition. It's built on things like price, quality, availability, and so forth, right on down to brand. And then that leads up to improved cost structure, enhanced customer value and shareholder value, or if you're not for profit concerned, a margin and stronger financial. I've highlighted in yellow where I think particularly population health may, in my opinion, contribute to enhanced value for the firm. And I think a lot of them have already been mentioned. So down at the bottom, culture, we heard J&J talk about that. Leadership, the role of the CEO and the CFO has already been talked about. Human capital, this is all about human capital when it's focused on the workforce and the relationship of health of the workforce to the community around it. Production and risk management, in terms of increased worker productivity, risk management in terms of the safety point that was made in the last panel. Over there on the far right, environment, safety and health again, employment and community. And then building up, I particularly highlighted price, because I think with a motivated workforce you can be more productive and decrease your input costs. Quality of the product that you have, again, a highly motivated workforce. And then brand or image if you decide to promote that in terms of being green. And then up to the top in terms of improved cost structure and enhanced customer value. I do this for the purpose of saying that it's not just us talking to each other. It's not the public health community just talking to businesses, but we've got to actually affect the business thinkers that businesses listen to as well. And might be good to look at some of these frameworks and try to explore where we think the value is, and perhaps someone who's far more qualified than myself to take a yellow marker and just make some marks and have some critical assessment of where value might be created in terms of some of these frameworks, which have a lot of traction and respect by a lot of business thinkers in terms of how value is created for customers in business. So aligned, common, and community purpose is where I'm going with this. So what are the mechanisms? Again, I apologize for using a healthcare example for thinking about this, but I want to make a couple of points. So this is, again, the diagram, the one that comes from the county health rankings, and again, the percentages, as I know there are different views of what those percentages should be, but we use the county health rankings. And we have healthcare up there at the top, and I've got it divided. We've got health behaviors in the top ones that are associated with death, and then we've got socioeconomic factors and environmental factors. In the far column, we went through a process with our board, and this is the slide I used with our board retreat. These are people we elect from our membership, from the community board members. We talked about how central it was to our mission in terms of improving health. The top boxes are central, the bottom ones are aligned. How many capabilities we had as an organization, obviously as a healthcare finance and delivery organization, a lot up in the top. Shared capabilities with public health from the middle perspective, since we touch so many people in our geography, but public health really does a lot there. And then down at the bottom, in terms of drivers like education and so forth, we need to participate with others in terms of shared capabilities. And so with that, and the other thing is we have inventoried in charts I don't have for you all of the activities we did that touched these various kinds of things. And the purpose of the conversation was, again, one, the key points that were made with the board was the fact that they didn't realize 20% of health was, 20% of what healthcare did was the factor that resulted, in better health. That was a startling assumption, which enlarged their thinking. And then second, it brought up the debate at the board about the fact that we weren't the health department. We're a healthcare delivery organization, but then it brought up the very good conversation about what our role was, therefore, in terms of these other factors. And so that is another conversation I've heard already come up in many kinds of ways about what the responsibility is to business. So now thinking about business. So I'm working toward a business chart, but I'm not a business guy exclusively. So healthcare, businesses buy health insurance. They are directly involved, many self-funded insurers and employers in terms of designing the benefit package and purchasing. They can shape the health care that's delivered, and they can put pressure on costs. They would argue, and they're probably right, that they haven't been as effective as they need to be. And the risk, of course, going forward is that they may not be as engaged in this going forward. But this is a tremendous factor, because if we don't reduce the healthcare fraction of GDP, we won't have resources available for education. So I think this is one way that business engages in the healthcare. In the healthy behaviors, they have the direct programming for the workforce, in public and private, and in partnership with public and private health, and obviously can work about that beyond their own workforce in ways in which have been described by others so far. And then we've had the examples of education, direct education involvement and so forth that have already come up from IBM and others. And then in the environment in terms of sustainable operations and green in terms of the image that might be created for business. So these are actions that are direct. In other words, this is what they can do thinking about the problem. But that is not sufficient. You've got to have partnership. And so we've been trying to think about the business model, which is the subject of this paper that David and I just wrote. Now, not business case or rationale, but the mechanism, how an organization or collective group creates, delivers, and captures economic, social, or other forms of value. And it represents the core business. So we took this concept of business and tried to create our thoughts about a community health business model. In other words, so what could the collection of businesses, healthcare providers, government, others coming together in a community, what would they need to be thinking about? So this is our starter list. We would welcome input as to what we're leaving out or whether we've got it wrong and so forth. But everybody needs to be engaged. It needs to be transparent. It needs to have leadership. And we've had some comments already about how CEOs, CFOs, and so forth are important, getting together and talking to each other about industry types of collaborations, for example. It needs common purpose-defined strategies. It needs resources. It needs effective and in-kind evidence-based interventions to work. It needs incentives, and we talk about moral, the idea that there's peer pressure, that it's an expectation, regulatory perhaps, regulatory in terms of the community benefit provisions for hospitals, in terms of coming to that, and financial, perhaps there are credits of some kind that can be given, tax credits or other sorts of things, or other incentives. And then knowledge of the state of the health of the community and its evolution over time, if we don't know where we are and what we're trying to do. And we've already heard comments about how the data is not yet sufficiently available at a granular enough data level for businesses to engage and personalize that data so that they can engage on it. So that needs to be there as well. And then it needs to be a cycle, in my opinion. So forth. And then the role of government in this. It needs the commitment and support of government, the willingness to engage. I put willingness to engage because government is not always willing to engage. Depends on who controls it at any point in time if you're in a community, and it swings back and forth. It needs to have policies, infrastructure, I'm thinking data here, incentives, information, and partnership. I should have put that on the chart with respect to really encouraging the dialogue and partnership between public health and these kind of broader collaboratives. So this is by no means, a very worked out sort of set of issues, but I think it's a set of issues that needs to be thought about. And then resources, we also talk about resources here, so that's been touched a little bit on so far. But how do you capture the savings from ineffective healthcare spending, the billion or so, the trillion or so, that different folks have estimated, the 20 or 30% of healthcare costs, the imbalance between the fraction of total healthcare costs that are spent for healthcare as opposed to social services. How do you really capture that and get that reinvested? Because if you squeeze money out of the healthcare system, it doesn't necessarily translate directly to either public health budgets or budgets for these sorts of collaboratives. We need a better return on investment in policy and programs outside of healthcare. We need to strengthen governmental funding for public health. So I hate to say taxation, but I have said taxation before. What is the mechanism by which we get that reinvestment? That is another topic we need to be thinking about. Philanthropy is certainly important in terms of developing the way and so forth, and then engaged corporate business leaders contributing in-kind leaders in particular for this conversation. We talked about the issue of the integrator or how it comes together. This is by no means settled. I think this diagram that David put out in his blog in 2010, and we repeated in the paper, talks about an integrator kind of bringing together these sorts of functions and providing the opportunity for these elements of the community business model to be addressed in a systematic fashion. But it could be that it's something like the IOM report in 2010, which had public health convening the conversation, the accountability model. It could be that. It could be something like Sandy Magden and her colleagues put forward in or heard their notion of accountable health communities in 2012. Or it could be like what I've seen in a conversation I was invited to in Boise, Idaho, where both the United Way and the Y organizations convened a large community conversation to answer the question, how can Boise be the healthiest community in the nation, and who needed to be engaged in that. It was a terrific meeting, engaged public health, healthcare, a broad segment of the business community, and so forth. Or it could be other. Or it could be, it could very much be related to the regional factors and culture that was kind of illustrated on the panel before lunch when we heard from Savannah, and then we heard from Spokane about differences in terms of some of the factors, the geography, and so forth. I'm not so sure anymore. I don't know how David feels about that. There's a one-size-fits-all sort of solution to this in every sort of geography in the country. But we need to develop the menu. We need to develop the relationship models. We need to start thinking about how these are done. We need to examine them critically in terms of how effective the different models are. And then what steps needed to be taken. This is, again, a perspective that we wrote for this roundtable. Set targets, extend a meaningful invitation to business, educate CEOs and C-suite executives, sponsor convenings with broader community partners, develop case studies of business that are already making progress in community health, promote triple aim collaboration with business, identify and create durable revenue streams for health activities. Building hierarchies lately, I can't resist thinking about these kinds of things. It seems to me, in terms of value creation, businesses definitely have to do level one. They need to satisfy directly their customer needs, create a return on investment. They need to provide good health and healthcare options, relevant education skills, and a good wage for the workforce. They need to put pressure on cost control. They need to contribute to a larger approach to health. So I often end my talks with this quote at the top, and for this particular presentation, that's what I have to say, and I'm sticking to it.